I would now like to introduce our guest speaker, Dr. Flavia DeSouza, who is a child adolescent psychiatry fellow at MedStar Georgetown, a board-certified adult psychiatrist working part-time at Howard University Hospital. She is also a National Substance Abuse and Mental Health Service Administration Fellow with the American Psychiatric Association at Georgetown University. She completed her general psychiatry residency and public psychiatry fellowship within the Yale Department of Psychiatry. Now introducing Dr. Flavia DeSouza.
Hi, everybody. I just want to check that you can hear me. If you can hear me, just put 1 in the chat, please. If you're listening and you can hear me, just put 1 in the chat. Wonderful. Wonderful. Thank you all for joining us this evening. We really appreciate your presence. It's going to make a huge difference in the conversation.
I'm sorry, Dr. DeSouza, can you speak up a little bit, please?
Sure. Is it difficult to hear me?
It's a little low.
Okay. All right. Let me see if I can make it. Can you hear me now?
Yes, that's better. Thank you.
Much better. Okay. Yeah, feel free to let me know whenever you can't hear me and I'll speak up. So I was introduced already. We'll get past this first page. I'm hoping that this session is going to be really informative for all of the persons who are coming in, where I will break down exactly what is trauma, what is PTSD, and some other things. Before we do that, I just want to remind everyone that the session is going to be recorded. What that means is that it's currently being recorded. It's going to be put on social media. If you do not want to have your image recorded, you can take your picture off, or your face recorded, you can take your picture off. You can feel free to type your responses to questions that are placed in the chat. I'll also say those questions out loud. These responses will be included in future replays. Because of the sensitive nature of this topic, I'm going to ask that participants do not divulge details about traumatic experiences that they have had, just to be mindful of every person who is participating here. And then also there'll be an opportunity for us to have a question and answer at the very end. I do want to take my time with this material. If we aren't able to get through everything, I've said to myself that that's okay. We can always have a follow-up session with the community. The most important thing for me is to make sure that people are really gaining something from our time here. Next slide, please. Okay. So I started to talk about what we're going to be discussing this evening. You'll see it on the screen here if you pay attention. Just on your Zoom screen. So we'll be going through just some definitions. I like to go through definitions at the beginning of my talks to make sure that people are we're all on the same page. So we'll be talking about trauma. We'll be differentiating that from PTSD, which is post-traumatic stress disorder. Then we're going to be moving into a conversation about children. I'm doing work with children now, and I'm really fascinated about how trauma symptoms present in children and what we can do to help. There's a phrase that's being used popularly now that's called being trauma informed. So we're going to review very quickly how we can be trauma informed caregivers, adults, and parents in children's lives. And of course, I'm going to just share a few resources that I find to be really reputable with you all at the very end of our conversation. Next slide, please. So that's me, and I've already been introduced, so we'll go to the next slide. Wonderful, thank you. So how I do interactive things on Zoom is through something called a chatterfall. And what is a chatterfall? It's an opportunity where individuals get to share their response in the chat, and it all comes in at the same time. So when I ask you a question, you'll type in your response, but you will not press enter right away. And then when I say press enter, you can enter it in. So everybody's response comes into the chat, almost like you'd say a waterfall. That's why we call it a chatterfall. Next slide, please. So our first question to the group is what one word comes to your mind when I say the word trauma? What one word comes to your mind when I say the word trauma? Now remember, you're going to type your response in the chat box, but don't click enter just yet. I will tell you when to click enter. And I'm going to give everyone a few moments here. Not 2 words, not 3 words, not a whole phrase, just one word. What one word comes to mind? So I'm going to ask those who are participating to go ahead and click enter for me, please. Oh, we're seeing yes, devastation, alarming, microaggressions, offline, harm, pain, fear, suffering, pain, dysfunction, PTSD, pain, overpowered. These are all right on. Next slide, please. And now we're kind of focused on psychological trauma, but for me, before I even got introduced to psychiatry, I used to think of trauma as physical damage to the body that can be seen. For example, a motor vehicle collision that leads to major injury and the need for trauma services in the emergency room. Next slide, please. Sometimes physical injury happens and has greater impact than we can appreciate. This is nicely illustrated in the film called Concussion. I don't know if any of you have seen it. Can I see hand raises for those who have seen this film? Not seeing any hand raises. Oh, good. So some people here have seen it. So let's take a look at this trailer together. Thank you. So Concussion is based on a true story about what happened to a doctor. His name is Dr. Bennett Omalu, and he was Nigerian born, a pathologist. And he tried to publicize that repeated concussions can lead to a form of brain damage known as chronic traumatic encephalopathy. And that's known as CTE in retired NFL players. So really what we're seeing here is that trauma, even physical trauma, may have a delayed response in an individual, and that delayed response can show up many, many years later. Now, we are here in a mental health presentation. Next slide, please. And I define trauma here as a deeply distressing or disturbing event. These pictures are showing two traumatic events that happened recently in the United States. The supermarket shooting in Buffalo, New York, on top right, and the school shooting in Uvalde, Texas, on bottom left. These shootings lead to psychological trauma and fall under the category of community violence. Community violence is exposure to intentional acts of interpersonal violence committed in public areas by individuals who are not intimately related to the victim. Next slide, please. Please drop in the chat the other categories of traumatizing events that you see illustrated on this slide. So we'll see pictures here, and there are different categories of traumatizing events. I want to see what you see on this slide. You can click enter if you put it in the chat box. Thank you. Thank you. Very good. So we're seeing here, and if you take a closer look at your screen, you can actually zoom in on your personal device. You're going to see a wide variety of exactly traumatic events which have great impact. So I've included here bullying, which is a deliberate and unsolicited action that occurs with the intent of inflicting social, emotional, physical, and or psychological harm to someone who often is perceived as being less powerful. You'll see here on the screen also a list of natural disasters with some images. They include things like hurricanes, earthquakes, tornadoes, wildfires, tsunamis, and floods, as well as extreme weather events such as blizzards, droughts, extreme heat, and windstorms. Many refugees, especially children, have experienced trauma related to war or persecution that may affect their mental and physical health long after the events have occurred. You know, we have refugees coming into the country at this time. Complex trauma, which is not included in our US-based code but is used overseas, describes both children's exposure to multiple traumatic events, often of an invasive and interpersonal nature, and the wide-ranging long-term effects of this exposure. Early childhood trauma, which we might illustrate with the little girl in the middle and the red marker growing through the top of the head, generally refers to traumatic experiences that occur to children ages 0 to 6. You'll see another little child with a teddy bear and a cast over their hand, and that is supposed to be illustrative of pediatric medical traumatic stress. And that refers to a set of psychological and physiological responses of children and their families to single or multiple medical events. There's also intimate partner violence, also referred to as domestic violence. And that occurs when an individual purposely causes harm or threatens the risk of harm. So even just the threat of the risk of harm to any current or past partner or spouse. And now, because of the time that we're living in, we might even consider something, a new category of pandemic stress. Next slide, please. So what is the difference between PTSD and trauma? I'd love to see some of your thoughts in the chat here. What is the difference between PTSD and trauma? And PTSD stands for post-traumatic stress disorder. What do you think is the difference between PTSD and trauma?
Hello?
Yes.
Yes, ma'am. But actually, it relates, right? Just like it said, PTSD is stress response that something has occurred in the past, but also it resurfaces in life situations. You know what I mean? It resurfaces, right? Because it really affects the the central nervous system in our brain.
Mm-hmm.
You know,
it sounds like you have some knowledge and experience, or you're in the field or something. You seem to know what you're talking about. Thank you for that. Anyone else? What's the difference between PTSD and trauma? And you can drop your thoughts in the chat as well. I welcome that as well, because I'm taking an active look at the chat while we're going along. Well, thank you to the person that just shared. You're exactly right. I'm seeing some additional responses here. Reflect on fight or flight. Exactly. Thank you so much for your participation. So I'm going to just try to break this down for all of us here. I just have 3 points on the screen that I really want those points to be your takeaway. Post-traumatic stress disorder is what happens when a person is not able to recover from a traumatic event. The providers diagnose PTSD using a code that helps us measure the impact that the trauma is having on the person's thoughts, their feelings or their mood and their behavior. After the person is exposed to a traumatic event, they must have symptoms greater than 1 month. So there's a timeline here to meet the criteria for PTSD. So I'm going to talk about the symptoms right now. These symptoms include trauma memories that come back to the person unwanted through dreams or even while awake. When they're reminded of the trauma, they have little control over their reactions, leading to physical and emotional distress. The discomfort and or sometimes even shared terror of this distress leads them to actively avoid being reminded about the trauma. People avoid these traumatic memories and feelings in different ways. Some people do it by working a whole lot. Other people by shutting down. Some people avoid by using substances like alcohol. The trauma can affect an individual so much that they might put down themselves. They struggle with shame and guilt, maybe even becoming very depressed. Since they are so on edge, they might have difficulty settling down, sleeping soundly. They might be afraid of what is around the corner to the point that they might even experience what appears to be paranoia. And like other mental health issues, PTSD leads to biological changes in the brain. Next slide, please. So what I want you to take away from this slide, we have a picture of the brain and there are different areas that are labeled. And on the top left, we see in red or pink, the prefrontal cortex. And on the bottom right, we see in baby blue, amygdala. Those are the 2 areas that I want to focus on this slide, the prefrontal cortex and the amygdala. The prefrontal cortex is the logical decision-making part of the brain. The amygdala is the emotional decision-making part of the brain. And I'm labeling it such because sometimes we make decisions out of logic, sometimes we make decisions out of emotion, or sometimes we make decisions out of a mix of the 2. The thinking and reasoning coming out of the prefrontal cortex is impaired. Something has gone wrong with it under the influence of trauma and PTSD. The emotional response that's coming out of the amygdala section is increased, it's heightened. So for example, just the perception of danger, even if there is no evidence that it is real or impending, can set off an automatic fight, flight, or freeze response. For example, you might hear footsteps behind you, or a person might just raise their hand to say hello. And that for you, because of how the brain has been rewired, can lead to distressing and difficult to control bodily and emotional reactions. Next slide, please. So I like to include a little good news break in my presentations. This is the good news. Most people who experience a traumatic event recover from it. Almost everyone following the traumatic event will have symptoms for a brief period of time. 2/3 of people recover, 1/3 of people do not. So that's why on the previous slides, I mentioned that PTSD really is what happens after you've had a traumatic event and you do not recover from it. We don't have time to go into this today, but oftentimes that's because of the nature of the event, the frequency of the event, and then the individual's vulnerability, their brain structure, their family history. All of those things impact both the external and the internal. Can I see, if everyone is staying with me and following me, can I see a 1 in the chat, please? If you're not, can I see a 2? If you're staying with me and you're following me, can I see a 1 in the chat? Okay, good.
1.
Great. If
No
there
problem.
ever any questions or clarifications, just type it in the chat. Someone will prompt me if I'm not paying attention closely, just to make sure that I slow down, because I really want people to take away important information today. Next slide, please. So this presentation has been focused so far on adults, and there's a reason, and I'm going to come back to that later. But I want to shift the focus to our children. And we're going to do 2 chatterfalls. We're going to do the one and then the other, and I'll give instructions. Remember, chatterfall is an activity that we do on Zoom. And when I ask the question, you put your responses into the chat. You don't click enter until I say click enter. And then everybody's responses come in the same time. It's almost as though you're seeing a cascading waterfall. So my first question is, are 6-month-old babies too young to remember ongoing traumatic experiences? Are 6-month-old babies too young to remember ongoing traumatic experiences?
I'm trying to, excuse me, ma'am, I'm sorry, I don't mean to interrupt. I'm trying to get my chat going on so I won't be, my voice won't distract someone else from focusing.
We appreciate that. Thank you.
And I received something from Allison, and I understand my voice could be triggering her or whatever, right? But I asked her to please stop muting me. But I'm trying to get my chat on right here on my iPhone. And
okay, so maybe somebody around you can help you. I don't know if you have anyone around you who might be able to help you.
I have the pen. Okay, my pen. Okay. Okay,
and then
thank you.
You're welcome. And then you can mute up, and then you can use the chat to communicate. And remember, we're going to have some time for live questions at the end. Okay.
Okay.
Thank you so much. Thank you so much. So I'm seeing here, it's so funny. I didn't even give the full instructions, but I think everybody is getting the drift by now. 1 means yes, 1 means yes, and 2 means no. So I'm seeing mostly 2s here. Okay. Now, if you could just give me a little time to go to the next one here so I can keep going with the presentation. Number 2 is the next chatterfall here. How would I be able to tell that a 3-year-old child is traumatized? How would I be able to tell that a 3-year-old child, really toddler, is traumatized? And I'm going to ask you to put your response in the chat and hold on to it. Don't click enter. Just hold on to it. I want everybody to have a chance to kind of process the information, put their response in, and then we'll see everything at the same time. Okay. Why don't you go ahead and click enter now for those who've put responses in the chat? Behavior, acting out, behavior. Anyone else? Shock reaction, physical reactions, behavior. So sensitivity in the body, behavior. Lack of eye contact. So you're seeing also maybe distress or changes in how the person is relating to other people along the lines of behavior as well. Excellent. Excellent. Thank you so much. Possible changes in toilet needs. Maybe they were toileting before and they're not able to toilet on their own again. So can I see the next slide? Okay. So to lay the foundation for this section, I want to use a metaphor of the trauma tree. We see here that each stage of childhood is metaphorically illustrated as part of the tree. You'll see the prenatal section is the roots. Emerging out of the earth is the birth. Infancy and toddlerhood is that first shoot coming out of the earth. Childhood is those first young branches, which matures into older branches, the adolescent years. And then adulthood are the leaves. So the first thing to take shape is the roots. And then after that, the trunk, the branches, and the leaves. Without a healthy root system, it is impossible for a tree to grow. When the root system is impaired, the tree will still grow, but it will not be able to maximally thrive. Sometimes you don't know that a tree is not thriving unless you have a healthy tree with a strong root system that is nourished by rich soil to compare the unwell tree to. So let's go to the next slide. Keep this tree in your mind. There are 3 common thinking errors that we have when we're dealing with infants. And when I use the term infants, I mean babies aged from 0 to 1, toddlers, and children who have been exposed to trauma, especially, and I'm talking here about ongoing trauma. We focus on the most salient behavior, not realizing how complex the situation might be. And I'm going to go through all of these and give examples. We have difficulty appreciating the impact of the trauma on the child's developing brain. We sometimes see the child as the problem instead of recognizing behavior as a sign of an issue that might be deeper and more troubling and in need of a different kind of intervention than we are accustomed to providing. So what do? We prune the tree instead of taking care of the root system. Next slide, please. Thank you. Next slide, please. So before I get into the content of this slide, I just want to tell you where some of these resources are coming from, and someone is going to drop them into the chat at some point. They're coming from the National Child Traumatic Stress Network and a paper that's talking about developmental trauma disorder. And the reason I'm mentioning this now is because PTSD as a diagnosis really does not fully take into consideration how to think about a child that has had traumatic experiences when they are pre-verbal, meaning separation from the mom or abuse in early infancy, exposure to violence or neglect in early infancy. And so there's a whole new category of diagnosis that's been introduced called developmental trauma disorder. So here we see myth 1, we focus on the most salient. We bring our children into care when teachers start to complain that they are misbehaving in the classroom. It's behavior that's noticed, it's a problem, and is sometimes treated at the expense of neglecting the root cause. Remember, we talked about the root system, which may be ongoing trauma leading to a developmental trauma disorder. Next slide, please. I want everybody to look at the age here, 0 to 2. We can see regulation and behavioral issues as early as infancy. Children who have been neglected or abused might scream or cry a lot, or may have lower functioning and appear to be withdrawn or shut down. Young children who experience trauma are at a particular risk because their rapidly developing brains are very vulnerable. Early childhood trauma has been associated with reduced size of the brain cortex. That's the outside part of the brain, the area responsible for many complex functions, including memory, attention, perceptual awareness, thinking, language, and consciousness. These changes may impact IQ and the ability to regulate emotions, and the child may become more fearful and may not feel as safe or as protected. Next slide, please. Let's take a look at this age range here, 3 to 6. In toddlerhood, we might start to notice excessive clinginess, aggression. Maybe the child is laying, or the toddler is laying hands on other children in the pre-K classroom. Difficulty focusing and following directions in the school environment. Next slide, please. Why might this be? There are many different domains of development: emotional, social, physical, psychological, spiritual. Ongoing trauma can lead to developmental delays in one or more of these domains. If there is any disruption, the infant, toddler, or child may behave or respond at an age that appears to be lower than their biological age in one or more of these areas. We often misunderstand the root cause of this issue and don't adjust our expectations accordingly. One way to think about this is for anyone who's had a tall toddler. A tall toddler may look older than their stated age, but they're really still a toddler. Because they appear to be older, there might be expectations that are not appropriate for that toddler. Similarly, what the literature shows is that Black children, girls and boys, are perceived to be older than white children are, and so the expectations for them are different. In the same way, a child who's been chronically traumatized may have a developmental delay, and the expectations may not actually meet or be appropriate for where the child is in one or more of the domains that I mentioned. Is everyone with me? Can I see a 1 if everyone is with me, a 2 if you're not? Okay, next slide, please. And I'm going to take my time with this slide here. Ongoing trauma or stressors can cause expression of our genes to change. We all have a genome that we inherit from our parents. We have the same genome in every single cell in our body, but every cell does not express every gene. This is why we have eyes different from ears, different from toes, different from noses, because cells express genes differently. They get different instructions. There is a process to regulate how genes are expressed in individual cells. There are proteins which cover up the cells so they can be expressed. They cover them up or open them up so that they can. This comes under our field known as epigenetics. Can someone just type epigenetics in the chat for me, please? Epigenetics. In the case of a trauma, thank you, Elon. In the case of a trauma, the environment or series of events is actually associated with altering how our genes express themselves. Ongoing trauma can actually alter gene expression and can lead to impaired neurodevelopment. This is development of the brain and nervous system. And plasticity, which means really, plasticity is just how much the brain can take in information and absorb and change and be flexible. Impaired neurotransmission, how things are communicated in the brain, and impaired stress response. So how you respond to stress might be greater than how other people respond to stress, and vulnerability to developing PTSD. Remember, it's a different diagnosis now later on in life. So you see the fine print on the side of the screen. Even if you can't see it, I have put their studies. So they talked about research in the very beginning. This is why we do research, to kind of gather up information to show exactly how this is happening. It's not something that, it's not a choice that a person is making. It's really a significant impact that these series of events are happening on brain functioning and development. Next slide, please. We often impose our adult thinking and standards onto the situation, and sometimes think of children as miniature adults when they're not, they're children. In doing so, we make the child the problem. I remember growing up and hearing people say that a child who was misbehaving a lot was too bad. When we frame it that way, we become more easily frustrated with, annoyed, and angry with our children. The next slide, please. The impact of this is very real. People with childhood histories of trauma, abuse, and neglect make up almost the entire criminal justice population in the United States. Physical abuse and neglect are associated with very high rates of arrest for violent offenders. I'm going to repeat that. People with childhood histories of trauma, abuse, and neglect make up almost the entire criminal justice population in the United States. Physical abuse and neglect are associated with very high rates of arrest for violent offenses. So we often think of people in prison as bad, probably more appropriate to think of them as traumatized individuals. Next slide, please. So what can we do about this all? How can we be trauma-informed adults in a child's life? Next slide, please. The first and most important thing is to take care of ourselves and our minds as best as we can. It's similar for anybody who's taken an airplane. I know everyone here might not have had that experience. When you go into the airplane, the air hostesses give instructions on what to do if you have an emergency in the air, and there might have to be an emergency landing on land or at sea. And they'll say, sometimes these masks will come down from above and it's supposed to supply oxygen. And if you're with a small child, you have to put your mask on before you put the mask on the child. In the same way, similar to putting on a mask first in the case of an emergency on an airplane, if we're not emotionally well as adults, it is even more difficult to be present and mindful with our children when we experience the stress of misbehavior or delayed development, because misbehavior and delayed development is stressful. Next slide, please. This slide provides additional guidelines on how to parent in trauma-informed ways. First is to understand and internalize the impact that trauma can have. We've been talking about that. We've just touched the surface. 2 is to recognize the signs and symptoms of the trauma. Be curious about the behavior and the responses. Just ask yourself, why? What's going on here? 3 is to respond in a way that does not re-traumatize the child. For example, beating the child if their behavior is an expression of trauma symptoms, or labeling the child as bad when they are hurting. The last is to understand the impact of the child's trauma on their own personal self-care. You can help them to feel safe by creating a consistent and structured environment. This might mean incorporating a consistent 5-minute routine with them at the end of each day. You can help the child in their own development by understanding the connection between their thoughts, feelings, and reactions. This might even be hard for some of us adults. In my work, a lot of people are not able to label how they're feeling. They're not able to note it because they really did not learn how to do that themselves. Sometimes people will use thoughts to describe their feelings. You can help children to understand, label, and express their emotions. This can be done through regular and safe imaginative play activities where you enjoy their excitement, as well as talking out loud about what they might be feeling. Say, I see that you are feeling sad, you're crying right now. In various situations, you might consider pausing and asking yourself, how is this child feeling? What might they be attempting to communicate to me in their own way? What are their needs in this moment? So let's take on the next slide a look at a video about how to understand and respond to an infant and toddler's needs.
Parents, we all wonder if we're getting it right. We want to know we're meeting our children's needs, helping them grow, and giving them all that we can. We try to combine our own experience of being parented with the advice of others and our own instincts and beliefs about what is best. And still, we so often worry that we're not succeeding. In a world that is always offering the next best parenting solution, the circle of security is based on decades of attachment research. Unlike many behavioral perspectives, it offers relationship tools to provide a new way of understanding your children's needs, creating lasting security for them and more satisfaction for you. The circle graphic has been created to help you know what to look for so you can read your children's behavior to guide you in meeting their needs. It's really not complicated. People of all ages have attachment needs. These needs can be divided in 3 ways. Let's look at this child. First, he needs to know the freedom and confidence to go out and explore his world. Second, he needs to feel assured that whenever he's ready, he can come back for comfort and protection. Third, he needs his caregiver to be in charge in a kind way. 3 basic needs that can be thought of as going out on the circle, coming in on the circle, and hands on the circle. Let's have a look in more detail. Feeling safe and supported, our children want to discover their world. When going out, they need to know that their exploration is encouraged, that we're right there watching over them, delighting in them, offering help when needed, and ready to enjoy their new adventures with them. And when they're coming in, they need us to refill their emotional cup. This means organizing their emotions and letting them know we are delighted to welcome them back, protect, comfort, and understand them. The key for us as parents is to remain strong and kind while knowing when to encourage their going out into the world and how to be available to welcome them back to us. It's crucial that we learn to identify our children's needs like this, because misreading them, or worse, missing them altogether, can cause pain and frustration. We all know how uncomfortable it can be to be held too close when we want to be out exploring, or kept at a distance when we need emotional support, or simply to be without someone who is bigger, stronger, wiser and kind, who we can trust to understand what we need when we're feeling lost, confused, or out of control. When a child misbehaves, the cause is often rooted in how safe and secure they're feeling. So it's not surprising that they behave well when a parent learns to tune into their child's needs on the circle in this way. And because our needs on the circle never disappear, learning to read cues can help you better understand and meet the needs of people of all ages, including your own. So that's all there is to it. Just know that at any given moment, your child is somewhere on the circle asking you to meet a need. Support my going out. Welcome my coming in. Be the hands that keep me safe by staying in charge and committed to helping me feel connected. And please remember this, there's no such thing as perfect parenting. At Circle of Security, we've come to realize that good enough is, well, good enough. All of us are going to miss needs on the circle time and again. Welcome to the club. But if we meet our children's needs enough of the time, the results will be happier, healthier, more secure children, and parents too.
So this video is from us, the Circle of Security Training International, and it focuses on developing a positive and healthy attachment between parents and their children. Now, why would I include this in a trauma presentation? It really helps you to understand better the child's trauma responses and how, as a parent, you can reduce the impact of trauma in the earliest stages, especially for those who are fostering or who are adopting or whose children have experienced trauma in other ways. The last thing that I wanted to say is that as part of your intervention as adults in children's lives, you can play a role by helping them develop positive relationships with peers and other adults. Next slide, please. Now, what you see here is a Circle of Security parenting training that's being offered by Georgetown MedStar. The telephone number is on the right side at the bottom of the screen, so you can give the front desk a call. And if this is something that you are interested in or someone in your community is interested in, they are welcome to sign up for the training. And you can see on the screen, it's a little bit small for me to read, but it's really looking at children of parents of children ages between 6 months and 6 years old. And the sessions will go over several weeks. They can be 12 weeks or 8 weeks long. And next slide, please. Where else can we seek help? Next slide, please. You can ask your child's pediatrician or your primary caregiver at their checkups. One of the reasons I like pediatricians is because children have to go to pediatricians for vaccinations or for other needs. Maybe they get sick or a cold or the flu or something. And there's an increased move to have pediatricians be supported by psychiatrists who are in the community. So psychiatrists will provide consultations with them. And with that, they are getting more education about how to treat basic mental health issues in their office, how to recognize it, how to treat it, but they're also more intimately aware of the services that are available in the community. The other thing is that when you are working with caregivers, it's important for you to advocate for the best care for your child with the physician or the mental health care provider. Sometimes we miss things, even if we don't want to as providers. Sometimes we just don't have our finger on the pulse. Sometimes we're moving a little bit too quickly because there are a lot of people that we have to see. I am going to talk about soon, we need to go back, please. We're gone too far. Thank you. Sometimes we don't know about what evidence-based solutions there are or treatments there are, so I'm going to mention that. These are backed by research shortly. So these are things that you can mention to your clinician about, to your provider about. They may not actually be aware of them. Next thing besides checking in with the pediatrician or the primary care doctor is to learn about and become involved in trauma-informed community-based organizations. Next slide, please. So I'm wondering if anyone knows about these organizations that are on the screen. There's two organizations here. As I was preparing and I was thinking about organizations in DC and asking around, there were two of the organizations that were recommended to me. Can I see a 1 if you know about the organizations already, a 2 if you don't? Okay, so it appears that most people here do not know about these organizations. So let me talk to you about them and you can go to the websites. OneCommonUnity.org is the website for One Common Unity. And it works to support youth through prevention, early intervention, and therapeutic treatment. And they work to meet the community's needs. And they are focused on community violence, and they have an arts-based framework. The next organization is called the WENT Center. That's short for Went Center for Loss and Healing. And if you go to the website, which is wentcenter.org, wendtcentr.org, you'll see that it's a nationally recognized program that is an organization that helps individuals cope with grief, loss, and trauma. And they provide services in the Washington, D.C. area. Next slide, please. The last two are kind of focused on the same thing, connecting with mental health care services in the school environment. How many of you know here that there are psychiatrists who are sometimes based in the school environment? A 1 if it's a yes, a 2 if it's a no. So it seems most people are aware of this. There are organizations that coordinate with schools to place psychiatrists in the schools part-time. And so students at their own convenience can just go into the clinic. And if they have any mental health issues, there's someone there that they might be able to talk to, either a school counselor, a social worker, a therapist, or even in some instances where a medication is needed, a psychiatrist. So you can try to connect with mental health services in the school, ask the school if there are mental health services. And I have here, seek out effective treatment with trained professionals. Next slide, please. So one thing that I am really passionate about is making sure that people make the most efficient use of their resources, limited resources, time and money. And I believe that some help is better than no help at all. But in an ideal situation, the help that you're being given should be working. And what I have listed here are research-backed evidence-based treatments for children and adolescents who have a diagnosis of PTSD, developmental trauma disorder, or having issues because they have been traumatized. So PCIT, parent-child interaction therapy, is an evidence-based treatment for young children who have behavioral problems. Child-parent psychotherapy, again, for young children from birth through 5, and helps families heal and grow after stressful experiences. Trauma-focused cognitive behavioral therapies and evidence-based treatment, helping children, adolescents, and their parents to overcome trauma-related difficulties, including child maltreatment. Cognitive processing therapy, CPT, has been shown to be effective in reducing the symptoms of PTSD, and that have developed after experiencing a variety of trauma events, including various kinds of assault, combat, or natural disasters. One of the things I want to say about CPT is that it can be delivered in a massed treatment way. What do I mean by massed treatment? You can essentially do the sessions back to back. So there are typically 12 sessions. You can do all 12 sessions over the course of 3 weeks if you have time every single day, or you can have it done over the weekend. That's called mass treatment, MASSED treatment. And lastly, I have here prolonged exposure therapy. It's an intervention strategy. It's a cognitive behavioral strategy that helps people confront their fears. It's a specific approach that teaches individuals to gradually approach trauma-related memories, feelings, and situations. Next slide, please. So I want to thank you for your presence and participation today, for your attention, for being here. We're now at 6:57. I did want to put our information again in the chat. If you could just slow down for me, you could go back to the last slide. Thank you. If you need resources, I personally am going to be focused on working with toddlers and young children next year. So we have a clinic that's dedicated to that. Next slide, please. We have a resource page here. Thank you for dropping that in the chat as well. We have the information for the 2 organizations I mentioned, as well as various websites that I feel are excellent. The National Child Traumatic Stress Network is full of resources, including some trainings that you can take on your own if you want to learn more about the impact of trauma and what you can do about it, how to understand it, how it manifests in children. Similarly, 0 to 3 is resources about trauma impact on young children. So this is infancy and toddlerhood, 0 to 3. Next slide, please. And we're not going to play these now, but this book on the left was written by the same psychiatrist that you saw talking to Oprah earlier in the presentation, the boy who was raised as a dog. And he talks about it's a bunch of short stories, and he talks about how trauma presents in children and how he was able to pick up on it in his practice. And then these 2 YouTube videos talk about some of the different therapy interventions that I mentioned earlier today. At this time, you can move to the next slide. Before I move to this, you can go back to the last slide. I wanted to see if there were any questions from the group. And then I'll talk a little bit about my work. Or is Elin, are you going to chair this section?
So there is one question. Do pediatricians provide annual ACT screening for children?
You know, I don't know. That's a really excellent question. And if you give us your information, I can get back to you on that. I'm presuming that you mean adverse childhood experiences by ACE. Okay, I don't know. But this is a good question because it helps to screen to see if the child may be vulnerable to, if the child is experiencing adverse experiences, and it may be coming out in how it is that they're relating to others through their behavior, their interaction, those kinds of things. So it's really just a check-in to see how the child is doing, and a vulnerability index score for if they might develop for future issues, especially with the school. Thanks for that question. Anyone else? If there are no other questions, I'm still entertaining questions. You can type it in the chat if you have questions. But I'd like everyone who participated to drop in the chat one new thing that they learned, or one thing that was reinforced today. One new thing that you learned, or one thing that was reinforced today. Thanks. If someone probably could take a note of that email address for me, and I'll work on getting back to him, that'd be great. So one new thing that you learned, or one thing that was reinforced today. Great. Great. So some individuals learned about a few resources in the DC area that they were unaware of. Visual of the brain, parts affected by trauma, what PTSD is, the definition of it, circle of security training, that trauma can have very early impacts, even in the prenatal stage, there's a lasting impact of childhood trauma. That doesn't mean that we can't do anything about it. In the same way that trauma can happen, the brain can be plastic, and these treatments have been shown to be effective. PTSD and trauma are difficult. Thank you. So I think we have a few moments. I think we have a few moments here, and you can guide me for those who are hosting, if I can move on to talk about my project.
Yes, I think that we're okay to stay a few more minutes. If the audience is able to, we're happy to stay a little longer. Okay,
so I'm running two projects now. One is not on the screen, one is on the screen. I'm going to start with the one that's not on the screen right now. I and a few other mental health providers are working with churches to coach leaders to be able to detect and think about trauma-informed ways of managing mental health issues in the congregation. We are doing focus groups at this time to present a curriculum. If you're interested in participating, or if you know someone who might be interested in participating, I'm going to drop my email in the chat, and you can email me directly. So we are developing a curriculum and a workbook for churches, training leaders who can respond in trauma-informed ways to individuals who have mental health issues, who might be struggling silently in the congregation. That's the first project. We're running focus groups right now. They're small focus groups where we'll be showcasing the curriculum, getting feedback, and hearing about other issues that you all might want to see addressed. The next project I'm running that project is called Faith in Mind. The next project I'm running is called Rooted in Transitions. Rooted in Transitions is a project that's focused on the mental health impact of immigration, and I'm specifically focused on individuals coming from the Caribbean region. We are conducting interviews right now, and these interviews are going to be recorded and publicized, where individuals talk about their transitional experiences. Sometimes people have lived experience of mental health issues, or they're just talking about the transition itself. And it's really to showcase a wide variety of voices, individuals who are from the Afro-Caribbean diaspora who've made the transition and who are navigating the system here with a focus on mental health. If anyone is interested, they can email the rootedintransitions@gmail.com on the screen, or myself, if they want to get plugged into this project. All interview volunteers are paid for their time. They're reimbursed for their time. And we usually typically have a conversation to make sure that they're comfortable with the process and coach them before we do the recording. Thank you all.
Great, thank you so much, Dr. DeSouza.